where we are essentially mapping the body's entire structural, mechanical, and protective systems from the inside out.
That's absolutely right. We're covering everything that provides structure and allows movement.
Everything.
From the microscopic electrical firing of a single muscle fiber, through the mechanics of a complex joint, right up to the systemic battles fought by the immune system in the joints, and of course, the protective barrier of the skin.
Our mission for you, the learner, is simple, but I think pretty ambitious. We are going to distill the highest yield patterns and the most critical contrasting concepts. We want to give you the clarity to distinguish between, say, the various types of arthritis or the half dozen injuries that all cause hand weakness, so you walk away with a clear, functional understanding of everything that holds us together and what covers us up.
And this really isn't about memorization. It's about connecting the dots.
Yeah.
We need to go past just naming a condition.
Right.
We need to focus on understanding the complex feedback loops, specifically connecting the precise mechanism of an injury or disease, whether it's a nerve lesion or a molecular defect, to the distinct presentation you see clinically.
That's the key.
That ability to link cause and effect is what turns data into true knowledge.
Okay, let's jump straight into that process then. Let's start with the electrical wiring of the upper extremity. When those wires get cut, the resulting deficit creates a kind of neurological fingerprint, doesn't it? It gives us an instant clue to the damage.
A fingerprint is the perfect word for it.
So we're going to map those signature symptoms, starting with the axillary nerve, which draws its roots from C5, C6.
So the axillary nerve is structurally very vulnerable, which makes its injury patterns incredibly specific. You should immediately suspect this nerve if the patient suffered either a fractured surgical neck of the humerus or an anterior dislocation of the humerus.
The classic trauma scenarios.
The absolute classic trauma scenarios. That's where you'll find it.
And what does that loss look like functionally? Because the deltoid is the star player here, right?
It is, absolutely. You'll see a notable contour change, a flattened deltoid muscle, because the deltoid is paralyzed and begins to atrophy pretty quickly.
You can see it just by looking.
You can. But the critical functional deficit is the loss of arm abduction, specifically in that crucial 15 to 90 degree range.
Oh, okay. Not from 0.
Right. Remember, the initial 0 to 15 degrees is handled by the supraspinatus, which is spared here. So that's a key distinction. You'll also lose sensation over the deltoid and lateral arm.
So if they can start the movement, but they just can't get the arm halfway up, the diagnosis points strongly to the axillary nerve being compromised.
Exactly.
Now let's move to perhaps the most famous compression injury, the radial nerve. Drawing from C5T1, we call it the drop nerve for a pretty obvious reason. Its functional loss is catastrophic.
Its path makes it highly susceptible to compression. The classic layman's term is Saturday night palsy, where the nerve is compressed against a hard surface, like the back of a chair, often when a person is deeply asleep or intoxicated.
Right. Or just in a weird position for too long.
For way too long. It also travels along the spiral groove of the humerus, which makes it extremely vulnerable to a midshaft fracture of the humerus.
And the functional consequence is just pure loss of extension.
It's a complete paralysis of the wrist and finger extensors. The wrist just hangs, creating the classic wrist drop.
So no ability to lift the hand back.
None. You also lose the ability to supinate effectively, and you will see paresthesias on the dorsal hand. A major clinical takeaway here is that you need wrist extension to stabilize the hand for an effective grip. If you lose extension, your grip strength suffers dramatically, even though the primary finger flexors are totally intact.
Wow, so that structural collapse of the wrist makes the entire hand functionally useless.
Pretty much.
Okay, let's tackle the median nerve next. Also C5T1. This is the ape and carpal tunnel nerve, and its presentation depends entirely on where the lesion is located, proximal versus distal.
Yes, the location is everything. If the injury is proximal, say high up from a supracondylar fracture of the humerus, the symptoms affect everything distal to that point.
So you get the full package of deficit.
The full package. The patient exhibits what we call ape hand due to atrophy and loss of function of the thenar eminence. But even more telling is the hand of benediction.
And this is the one that's a bit tricky because it only appears when you ask the patient to do something specific.
Exactly. This posture only appears when the patient is trying to make a fist. They physically can't flex the lateral 2 or 3 fingers, the first, second, and third digits, because the lateral lumbricals and flexors are paralyzed.
The hand looks like it's making a sign of the cross or blessing someone because those fingers are sticking straight out while the others are flexing.
That's the image, yeah.
Yeah. But as you said, the story changes completely when the injury is distal, like in carpal tunnel syndrome.
In CTS, the entrapment is at the wrist. So the forearm muscles that control that gross finger flexion are totally spared. The key complaints here are sensory.
Pain and numbness.
Pain, numbness, and paresthesias over the lateral 3.5 fingers, often waking the patient up at night. You do still eventually get the cannar atrophy, that apan posture, but the deflexors are fine.
Now, what if the lesion is extremely distal, like a superficial laceration right on the palm?
That's a pure motor injury, affecting only the recurrent branch of the median nerve, because this branch supplies the thoracic muscles opposition, abduction, and flexion of the thumb. Losing it gives you an immediate apan posture. But critically, the sensory function remains intact.
A very high-yield distinction.
Absolutely.
The final major nerve, then, is the ulnar nerve, C8T1, known as the claw nerve. This one is notorious for its path along the elbow.
It is. Proximally, it's incredibly vulnerable at the medial epicondyle, the funny bone area. A fracture there is a common cause.
And distally?
Distally, you see injuries often from a fractured hook of the hamate, which is part of the Guyane canal structure. This is the classic injury for frequent, prolonged contact with handlebars, so it's very common in competitive cyclists.
And the signature presentation is the ulnar claw, affecting the ring and pinky fingers.
Yes, the 4th and 5th digits. Plus, you get loss of sensation over the ulnar 1.5 fingers and visible hypothenar atrophy. The ulnar nerve governs so many of the intrinsic hand muscles, which is why its loss causes such a severe deformity. It's a concept we'll need to circle back to when we dissect all the different claws.
Okay, so that gives us the individual wires, but we need to zoom out and look at the main control panel, the brachial plexus. This is where everything bundles, gets sorted, and routed, running from roots C5 through T1.
The organization here is key. We remember the structure with the mnemonic. Remember to drink cold beer roots, trunks, divisions, cords, and branches. Understanding the trunks is vital because the upper and lower trunks are the sites of the two most important traction injuries.
And we should also remember that the plexus, along with the subclavian artery, passes through the scalene triangle.
Right, between the anterior and middle scalene muscles.
Which brings us to thoracic outlet syndrome, TOS.
Exactly. TOS occurs when the lower trunk of the brachial plexus, or the subclavian vessels, or both, get compressed in that very tight space. This is commonly associated with an anatomical variant, like a cervical rib, or sometimes a mass, such as a Pancoast tumor in the apex of the lung.
And TOS often presents like a partial Klumpke's palsy.
Precisely. You get atrophy that resembles Klumpke palsy because of the compression of the lower trunk, C8T1. But the added vascular compression can cause ischemia and edema in the arm. That's a crucial difference.
Okay, now let's differentiate the classic traction palsies, starting with Erb's palsy, the waiter's tip.
Erb's palsy is an upper trunk lesion affecting the C5-C6 roots. The mechanism is a force that widely separates the head and the shoulder.
A stretch injury.
A major stretch injury. Think birth trauma with a difficult delivery, or in an adult, a heavy fall that violently separates those two structures.
And the resulting posture is visually diagnostic. You can spot it from across the room.
You really can. The arm is adducted, internally rotated, and pronated, mimicking a server expecting a tip. This is all due to the weakness of the deltoid and supraspinatus, so you lose abduction and external rotation, and the loss of function in the biceps and brachialis.
And the opposite of that is Klumpke's palsy, the claw hand form.
That's a lower trunk lesion, so C8T1 roots. The cause is the opposite pull, an upward force on the arm.
Like grabbing something while falling.
Exactly. An infant whose arm is pulled during delivery, or an adult grabbing a tree branch during a fall. The functional loss is the intrinsic hand muscles, leading to that claw hand posture because the MCP joints are extended and the DIP and PIP joints are flexed.
We can't talk about the shoulder without mentioning the spectacular deficit caused by a lesion of the long thoracic nerve.
Ah, yes, the winging of the scapula. This is a lesion of the long thoracic nerve, which has roots from C5, C6, and C7.
And this nerve only supplies one muscle, right?
Just one.
Yeah.
The serratus anterior. And that muscle is absolutely essential for anchoring the scapula to the thoracic wall. Without it, the scapula just wings off the back.
So it looks like a little wing poking out.
It does. And functionally, the patient loses the ability to effectively abduct their arm above the horizontal position, so typically above 90 degrees.
That brings us perfectly to the mechanics of the shoulder itself, specifically the rotator cuff. These four muscles, the ischius muscles, are really the unsung heroes of shoulder stability.
They absolutely are. The ischial mnemonic covers, supraspinatus, infraspinatus, teres minor, and subscapularis. They don't just move the arm, they pull the humeral head into the glenoid fossa. providing dynamic stability to a joint that is inherently unstable because of its massive range of motion.
Okay, so the supraspinatus coming from C5, C6, and the suprascapular nerve is where the action starts.
Exactly. It initiates abduction, covering just the first 0 to 15 degrees of movement.
And it's the most commonly injured one.
By far. Its tendon is the most commonly injured rotator cuff element. It's prone to degeneration and impingement, and we test it clinically with the empty can test.
Okay, and the infraspinatus and teres minor handle external rotation.
Yes, infraspinatus is the primary external rotator, also powered by the suprascapular nerve. Teres minor is also an external rotator, but it's powered by the axillary nerve. And then the subscapularis from the upper and lower subscapular nerves is the powerful internal rotator.
Understanding the aspirants muscles leads us to the full relay race of movement, arm abduction step by step. This is a great clinical pattern that uses the SALT acronym connection.
It's a great one. If a patient has a complete inability to raise their arm, you need to check the sequence. The first 0 to 15 degrees is the supraspinatus, powered by the suprascapular nerve.
Then the next big chunk of movement.
From 15 to 90 degrees, that's the powerful deltoid, powered by the axillary nerve. Now, if those parts are fine, but the patient still can't get their arm overhead.
That's when you look for the bigger stabilizers, the scapular rotators.
Exactly. Above 90 degrees, you need the trapezius, which is powered by the accessory nerve, and the serratus anterior, powered by the long thoracic nerve.
So a failure at, say, 100 degrees means we're checking the neck and back innervation, potentially looking for that subtle scapular winning we just talked about.
That's right. That sequence is highly actionable knowledge. It's the roadmap for orthopedic assessment of the shoulder.
Perfect. That transition takes us down to the detail of the wrist and hand. When we look at the intricate architecture of the carpal bones, the scaphoid fracture immediately flags a serious circulatory risk.
It really does. The scaphoid is the most commonly fractured carpal bone, typically resulting from a fall onto an outstretched hand, a Fuchs injury. The clinical concern is purely anatomical. The blood supply to the scaphoid is retrograde.
Meaning it flows backward.
It enters distally and flows backward toward the proximal part of the bone.
Which means if the fracture line interrupts that distal blood entry point, the proximal fragment of the scaphoid is left completely starved.
Precisely. There's a very high risk of avascular necrosis, or AVN. This is a critical point because occult fractures, those that aren't initially visible on an X-ray, are common.
So you have to be suspicious.
You have to be. Clinically, if you find tenderness in the anatomical snuff box, you must treat it aggressively as a fracture to prevent AVN, regardless of what the initial X-ray shows.
And while we're on carpal injuries, we mentioned the hook of the hamate fracture, which is primarily important because of its associated nerve involvement.
Yes, the fracture itself can be caused by the trauma of striking the palm, but the greater consequence is that the fracture fragment often compresses the ulnar nerve as it passes through the Guillain Canal.
Causing Guillain Canal syndrome.
Right. That's the numbness and weakness often seen in competitive cyclists or anyone putting prolonged pressure on that specific area of the palm.
Okay, let's solidify the roles of the hand muscles. We have to master the intrinsic muscles to understand the pathology we just discussed.
Grouping them by their innervation is the high-yield strategy here. The thenar muscles, all innervated by the median nerve, are for opposition, abduction, and flexion of the thumb, the OAF mnemonic.
And the hypothenar muscles on the other side.
All innervated by the ulnar nerve. They handle the opposition, flexion, and abduction of the fifth digit.
And then the intricate movers, the lumbricals, and the interossae.
The lumbricals are a bit of a hybrid. The median nerve handles the lateral 2, and the ulnar nerve handles the medial 2. They're responsible for that strange but vital movement, flexing the MCP joints while extending the DIP and PIP joints.
Kind of making an L shape with the fingers.
Exactly. They essentially keep the fingers straight at the tips while curling at the base. And the interossae are purely ulnar supplied. The mnemonic is DAB and PAD, dorsal interossei abduct, and palmar interossei adduct.
This detail on the intrinsic muscles is the Rosetta Stone for understanding those pathological hand postures we talked about. So let's tackle differentiating the claws in the hand of benediction head-on. This requires understanding that delicate balance between the extrinsic flexors and the intrinsic lumbricals.
The phenomenon of clawing is not simply paralysis. It is the visible result of the loss of the lumbrical function, which leaves the powerful extrinsic extensors, all supplied by the radial nerve, to act completely unopposed.
So the extensors pull back on the main knuckle?
They pull the MCP joints back into extension, while the unopposed extrinsic flexors put the tips of the fingers into flexion.
So if you have a distal ulnar nerve lesion, you lose the medial two lumbricals. When the patient tries to extend their fingers, the ring and pinky finger claw because their intrinsic muscles are out, but their extrinsic flexors are still working.
The crucial contrast to that is the hand of benediction. This posture only appears when the patient tries to make a fist. It's a dynamic action.
So not at rest.
Not at rest. A proximal median nerve lesion knocks out the flexors for the lateral fingers. So when they attempt to flex, the fingers served by the median nerve remain straight, while the ulnar innervated fingers flex normally.
This is the moment of insight then. The ulnar claw is visible at rest or when attacking extension. It's an exaggeration of a static deficit. But the hand of benediction is visible only when attempting flexion, a dynamic inability to flex.
And just to close the loop on this, if you have a proximal ulnar nerve lesion, you lose the finger flexors for the fourth and fifth digits, making a fist difficult. And if you have a distal median nerve lesion, like in carpal tunnel, you get the medial claw when extending the fingers at rest, just like the ulnar claw, but affecting the second and third digits. The location determines which subset of intrinsic muscles is compromised.
That makes the pathology so much more tangible. Okay, let's pivot now to the lower half of the body and jump into knee assessment. We have a whole suite of orthopedic maneuvers designed to quickly diagnose ligamentous or meniscal instability.
These tests are essential tools, absolutely. For the cruciate ligaments, we are testing for anterior or posterior translation of the tibia relative to the femur. The anterior drawer, and especially the more sensitive Lachman test, assess for an ACL rupture.
And what are you looking for?
If the tibia slides too far forward, or if there's a soft endpoint instead of a firm stop, the ACL is likely torn. The posterior drawer test does the same thing, but assesses the PCL.
And for the collateral ligaments, the sides of the knee, we apply stress tests.
Right. The valgus stress test involves applying an abduction or outward force. If there is pain or excessive medial space widening, especially when the knee is flexed to 30 degrees, that confirms a medial collateral ligament or MCL injury.
And the opposite for the LCL.
The varus stress test applies an adduction or inward force to confirm a lateral collateral ligament injury.
And detecting meniscal tears requires rotation with compression, the McMurray test.
The McMurray is a really elegant test. We use the LIME acronym to remember the rotation direction. Lateral rotation stresses the lateral meniscus. Internal rotation stresses the medial meniscus.
And a positive test isn't just pain, is it?
No, you're often looking for a palpable or audible pop or click as the torn meniscus fragment gets caught between the femoral condyle and the tibial plateau. That's the real tell.
Okay, now let's apply the same anatomical mapping concept we used for the arm to the lower extremity nerves.
We can begin with the femoral nerve, which comes from L2 to L4. Its primary role is extending the leg via the quadriceps. If you have an injury, often from a deep hematoma, a retroperitoneal hemorrhage, or a psoas abscess pressing on it, you lose leg extension, and the patellar reflex is diminished.
The trunk line for the entire lower extremity is the massive sciatic nerve from L4 to S3.
It's the thickest nerve in the body. It handles motor and sensory for the posterior thigh, but its clinical significance often revolves around its vulnerability to compression from a herniated disc or piriformis syndrome before it splits.
And because it splits into the common peroneal and tibial nerves, a proximal sciatic injury affects everything distal.
That's right, it's a double whammy.
And that split brings us to the famous common fibular peroneal nerve from L4 to S2, the foot drop nerve.
The common peroneal nerve is uniquely exposed. It wraps right around the lateral aspect of the leg near the fibula neck, making it really prone to trauma or compression, like from crossing your legs for too long.
And its function is PED.
PED. Peroneal everts and dorsiflexes the foot.
And loss of that function is immediate and necessitates a drastic change in walking.
It does. That's the classic foot drop. The patient has to lift their hip high, what we call the steppage gait, to prevent their toe from dragging on the floor. They also lose sensation on the dorsum of the foot.
The antagonist to that is the tibial nerve from L4 to S3.
The tibial nerve is the tippy nerve. Tibial inverts and plantar flexes. Injury, whether it's proximal trauma or a distal issue like dorsal tunnel syndrome, results in an inability to toe walk. And with proximal lesions, the foot is held everted and dorsiflexed because of the unopposed peroneal muscles.
Okay, we absolutely must address the gluteal nerves and the critical diagnostic test they relate to, the Trendelenburg sign.
This sign identifies failure of the hip abductors, which are supplied by the superior gluteal nerve from L4 to S1. This nerve controls the gluteus medius and minimus, muscles that are essential for pelvic stability when you're standing on one leg.
So an injury causes The Trendelenburg gait or sign. Walk us through the mechanism of that.
When the patient stands on the injured leg, the pelvis on the other side, the unsupported side, tilts or drops down. This happens because the weakened abductors on the weight-bearing side just cannot stabilize the pelvis.
And the critical insight is that the lesion is on the contralateral side of the pelvic drop.
Exactly. This nerve is also notoriously at risk of iatrogenic injury from misplaced gluteal injections.
And the inferior gluteal nerve, L5 to S2.
That's the motor for the gluteus maximus, the main hip extensor. A deficiency there means the patient has difficulty with powerful extension movements, like climbing stairs or rising from a low chair.
Rounding out the nerves, we have the pudendal nerve, S2 to S4.
The pudendal nerve supplies the external sphincters, both anal and urethral, and perineal sensation. It is often damaged by a stretch injury during childbirth or chronic compression from cycling. It's also an important landmark for anesthesia. Clinicians block it near the ischial spine during obstetric procedures.
Okay, let's connect this peripheral nervous system back to the spine with lumbosacral radiculopathy, the presentation of a disc herniation. The location is everything here.
We have 3 high-yield patterns you have to recognize. First, the L3-L4 disc herniates and typically hits the L4 nerve root. This impacts the knee.
Okay.
So you'll see weakness of knee extension because of quadriceps and a diminished patellar reflex.
Next, the L4-L5 disc hits the L5 nerve root.
L5 controls dorsiflexion. So damage there causes weakness of dorsiflexion, a foot drop, or difficulty performing the heel walk. It's important to note that L5 radiculopathy typically does not affect a major reflex.
That's a key negative finding. And finally, the L5-S1 disc hits the S1 nerve root.
This affects plantar flexion. You see weakness of plantar flexion, difficulty with toe walking, and a diminished Achilles reflex. We can also diagnose these issues clinically using the straight leg raise test, which indicates nerve root irritation if it causes pain below the knee, or the femoral stretch test for the higher roots, L2 to L4.
Here's where it gets really interesting. We are shifting from the map of the body to the engine that powers it. We've mapped the broken wiring and the resulting functional deficits. But what exactly is the healthy underlying mechanism? We're diving deep now into the micromechanics of the motor neuron action potential to muscle contraction. It's a beautifully choreographed sequence of electrical and chemical events.
This molecular dance needs to be seen in 3 acts: initiation, excitation, contraction, coupling, and the cross-bridge cycle.
Okay, Act 1.
Act 1, initiation. The action potential arrives at the neuromuscular junction. This opens voltage-gated calcium channels and induces the release of acetylcholine, or ASH, into the cleft. ASH then binds to the postsynaptic receptor, depolarizing the motor end plate.
And then Act 2, the coupling. This is the critical link between the electrical signal and the physical pull. The depolarization doesn't just stay on the surface, it travels down the T-tubules deep into the muscle cell.
And that electrical signal triggers a conformational change in the voltage-sensitive dihydropyridine receptor, or DHPR, on the T-tubule membrane. And this DHPR is physically coupled to the ryanodine receptor, or RYR, on the sarcoplasmic reticulum, the SR.
So the electrical current hits the DHPR, which basically pulls the plug on the RYR, releasing a flood of calcium from the SR into the muscle cell cytoplasm. The calcium is the molecular switch.
That is the moment of truth, Act 3, the cross-bridge cycle. That calcium binds to troponin C. That binding shifts the position of the tropomyosin molecule, which had been physically blocking the binding sites on the thin actin filament.
So now the sites are exposed.
Now they're exposed. The myosin head, which is already cocked with ADP and inorganic phosphate, now binds strongly to the exposed site on the actin, forming the cross-bridge.
And then the power stroke.
And the power stroke occurs when the inorganic phosphate is released, causing the myosin head to pivot and pull the thin filament inward. Crucially, the A band stays the same length, while the H and I bands shorten.
And the final step of that pull requires a fresh unit of energy.
It does. A new ATP molecule binds to the myosin head, which causes the immediate detachment of myosin from actin. Hydrolyzing that ATP back to ADP and phosphate resets the myosin head for the next cycle. Simultaneously, the circuit pump actively returns calcium back to the SR, causing relaxation.
10 steps, a fraction of a second, done perfectly.
Or perfect sequence.
Now that we understand the mechanism, we see why muscles look different depending on their job. We have 2 main muscle fiber types, type I and type 2.
Type I fibers are the slow-twitch endurance fibers. They are dark or red because they are packed with myoglobin and mitochondria. They use sustained aerobic metabolism oxidative phosphorylation to prevent fatigue.
The isoredox mnemonic.
Exactly. They're built for marathon running or maintaining posture for hours.
And type 2 are the fast-twitch power fibers.
They are lighter or white with fewer mitochondria and less myoglobin. They rely on fast, high-power anaerobic glycolysis. They fatigue very quickly but generate massive force.
These are the two fast white antelopes.
Built for sprinting and weightlifting. And the body can adapt these fibers. Hypertrophy is the addition of sarcomeres in parallel, while atrophy involves dismantling myofibrils via the ubiquitin proteasome system.
We also need to differentiate that skeletal contraction mechanism from smooth muscle contraction, which lacks T-tubules and the troponin switch.
The initial calcium influx is different in smooth muscle. It uses L-type voltage-gated calcium channels and agonist signaling, like from hormones or neurotransmitters, to primarily draw calcium in from the outside.
And since there's no troponin, the regulatory switch has to be different.
The switch is calmodulin, or CAM. Calcium binds to calmodulin, and that complex then activates myosin light chain kinase, or MLCK. MLCK then phosphorylates the myosin light chain, allowing the myosin head to bind to actin and contract.
And relaxation is just the reverse.
Relaxation is driven by myosin light chain phosphatase, or MLCP, which removes the phosphate. Nitric oxide is a key modulator here, using the cGMP pathway to promote that relaxation.
Before leaving the mechanics, let's quickly differentiate the two sensors that give our muscles spatial awareness, so muscle proprioception and reflexes.
The muscle spindle is your sensor for length and the speed of stretch. It uses IA-N2 sensory fibers. If a muscle is stretched too fast, the spindle initiates the agonist muscle contraction, that's your basic deep tendon reflex, while simultaneously sending a signal to inhibit the antagonist muscle. It prevents overstretching.
And the Golgi tendon organ, or GTO?
The GTO is your internal safety breaker. It senses muscle tension. It uses IB sensory axons. If the tension gets too high, the GTO reflexively leaves to an inhibitory interneuron firing for the agonist muscle, causing immediate relaxation. This prevents you from literally pulling your own muscles or tendons off the bone when you lift something that's way too heavy.
That structural balance is defined not just by soft tissue, but by the skeleton itself. Let's pivot to bone formation and hormonal control. We have two basic methods for building bone.
The vast majority of the skeleton, the appendicular skeleton and much of the axial skeleton, is formed by endochondral ossification. This is a process where chondrocytes first lay down a cartilaginous model, which is then gradually replaced by bone. This process is the one that goes wrong in achondroplasia.
And the other method is membranous ossification.
That's where woven bone is formed directly, without a cartilage precursor. This is how the calvarium, the skullcap, facial bones, and the clavicle are formed.
Okay, let's zoom into the cell biology. Bone health depends entirely on a vital, necessary opposition: the builder versus the dissolver.
The builder is the osteoblast. It comes from mesenchymal stem cells, it secretes the collagen matrix or osteoid, and it catalyzes mineralization, which we measure via alkaline phosphatase or ALP.
And the dissolver is the osteoclast, the one that crushes.
The osteoclast differentiates from fused monocytes and macrophages. It creates an acidic microenvironment to dissolve mineral and uses collagenase to break down the matrix. Its activity is ramped up when rank-alkyl, a ligand expressed by osteoblasts, binds to the rank receptor on the osteoclast precursor.
So the builder cell actually tells the dissolver cell when to work.
It does. And the decoy receptor, osteoprotegerin or OPG, inhibits this process. It's a very tightly controlled system.
And this mechanism is central to hormonal regulation. How does parathyroid hormone, or PTH, manage this balance?
PTH has a strange dose-dependent dual role. If you administer PTH analogs like teriparatide at low intermittent levels, the effect is primarily anabolic. It stimulates osteoblast activity and bone formation.
But chronic high levels are the opposite.
Chronically high levels of endogenous PTH, as you'd see in hyperparathyroidism, are powerfully catabolic. They override the builders and massively increase bone resorption, which can lead to a condition called osteitis fibrosis cystica.
And the protective role of estrogen.
Estrogen is absolutely critical. It acts as the regulator. It promotes the survival of osteoblasts while inducing the programmed cell death or apoptosis of osteoclasts.
So it keeps the dissolvers in check.
It does. And when estrogen levels plummet, particularly after menopause, this regulatory brake is released. Bone remodeling accelerates uncontrollably, and resorption outpaces formation, leading directly to the massive increase in osteoporosis risk.
That structural balance is constantly being tested by trauma and overuse. Let's jump into part 4 and look at some common injuries, starting with clavicle fractures.
They are exceedingly common, typically occurring in the middle third segment. In kids, they are often secondary to birth trauma or a fall. In adults, it's usually direct trauma or a fall onto the shoulder. The presentation is immediate. Shoulder droop, shortening of the clavicle, and the arm held, adducted, and internally rotated.
In the elbow, overuse tells a specific story based on where the pain lands.
If the pain is near the medial epicondyle, it's medial tendinopathy, or golfer's elbow. It's associated with repetitive wrist flexion, as you would use in a golf swing or pitching.
And if it's on the other side.
If the pain is near the lateral epicondyle, it's lateral tendinopathy, or tennis elbow, which is linked to repetitive wrist extension, the classic backhand motion.
Back to the wrist, we need to detail the systemic nature of carpal tunnel syndrome.
CTS is median nerve entrapment between the carpal bones and the transverse carpal ligament. Symptoms are sensory pain, paresthesia, numbness in the lateral 3.5 fingers, and often worse at night. Thenar atrophy is a late motor sign.
What's fascinating are the associated conditions that predispose someone to CTS. Why do they matter so much?
They clue you into a systemic problem causing swelling or deposition within that very confined space. Conditions like rheumatoid arthritis, hypothyroidism, which causes fluid retention, diabetes mellitus, acromegaly, and especially amyloidosis can all cause the tunnel volume to decrease, leading to entrapment.
So it's not always just a local overuse problem.
Not at all. That's why you always check thyroid function and blood glucose in these patients.
Moving down the leg, let's revisit the unhappy triad in the knee. This is a classic high-energy sports injury.
This specific injury pattern results from a strong lateral force impacting a planted foot, for instance, a football tackle from the side. It classically tears the 3 key structures: the anterior cruciate ligament, ACL, the medial collateral ligament, MCL, and the medial meniscus.
And why is the medial meniscus involved more frequently than the lateral?
Because of its tighter anatomical connection. The medial meniscus is firmly attached to the MCL. So when the MCL is torn by that valgus, or outward stress, the medial meniscus often gets ripped right along with it. The lateral meniscus is far more mobile and can often escape.
Let's clarify the 2 common bursitis conditions around the knee. Prepare-teller bursitis.
That's housemaid's knee. It's an inflammation of the bursa directly in front of the patella, caused by repeated kneeling or trauma. It's a localized swelling, and it's typically painless unless it gets infected.
And the posterior swelling. The popliteal cyst or Baker cyst.
This is a fluid collection, the gastrocnemius semimembranosus bursa, found in the back of the knee. It often communicates with the synovial space and, critically, is almost always associated with underlying chronic joint disease, like severe osteoarthritis or rheumatoid arthritis.
Further down the leg, 2 common running injuries. First, iliotibial band syndrome.
An overuse injury causing lateral knee pain. It's inflammation and pain developing secondary to the friction of the thick iliotibial band as it slides repeatedly over the lateral femoral epicondyle during running.
And tibial medial stress syndrome, or shin splints?
This is diffuse tenderness along the shin, a common complaint in new military recruits or runners who rapidly increase their mileage. It's caused by an imbalance of bone remodeling. Bone resorption outpaces bone formation in the tibial cortex. It's a sign of severe mechanical stress.
And the classic foot pain, plantar fasciitis.
Inflammation of the plantar aponeurosis causing severe heel pain. The hallmark symptom is that the pain is classically worst with the very first steps in the morning or after prolonged rest, and it improves somewhat with activity throughout the day.
Okay, now we come to the critical immediate emergency, limb compartment syndrome. We need to focus on why this is so devastating and what the immediate red flag is.
The pathophysiology here is a runaway train. Trauma or excessive swelling causes the pressure within a non-expansible fascial compartment to rise rapidly. This pressure collapses the venous outflow, which causes more edema, and even higher pressure, which eventually collapses arterial inflow.
And the muscle just dies.
The muscle tissues quickly become ischemic and necrotic.
The resulting damage can lead to amputation, rhabdomyolysis, and acute tubular necrosis. We use the 5 Ps to diagnose it, but 1 P is the absolute sentinel sign.
Pain out of proportion to the physical exam findings is the most prominent and severe sign. You must suspect it if a patient reports excruciating pain that doesn't respond to usual analgesia, especially pain upon passive stretching of the affected muscles.
And the other Ps?
The other Ts, pallor, paresthesia, pulselessness, and paralysis, are late, dangerous signs. Immediate surgical fasciotomy is required to save the limb.
That sets a strong baseline for acute trauma. Let's shift our attention to childhood musculoskeletal conditions, where the vulnerability lies in growth plates and developing anatomy.
The classic is radial head subluxation, or nursemaid's elbow. This is the most common elbow injury in young children, typically under 5. It's caused by a sudden sharp pull on the arm, like an adult swinging a child or yanking their hand, which causes the annular ligament to slip over the radial head.
And the presentation is usually heartbreakingly simple. The child just refuses to use the arm, holding it slightly flexed and pronated, and they are often inconsolable.
Another overuse injury related to rapid growth is Osgood-Schlatter disease. This is a progressive anterior knee pain frequently seen in active adolescents who run and jump during their growth spurt. The repetitive strain causes a microavulsion of the secondary ossification center of the tibial tuberosity, where the patellar tendon inserts.
Moving to the hip in the young patient, we have 2 serious conditions. First, developmental dysplasia of the hip, DDH, in newborns.
DDH is an abnormality in the development of the acetabulum, which prevents the femoral head from seating properly. Risk factors include breech presentation and female gender. Diagnosis relies on the physical maneuvers Ortolani, which reduces a dislocated hip, and Barlow, which dislocates a reducible hip and ultrasound in infants older than 4 to 6 months.
And the classic presentation of the obese adolescent male with a limp, slipped capital femoral epiphysis, SCFE.
This is a mechanical failure of the growth plate. The femoral head epiphysis literally displaces relative to the femoral neck. We visualize it as a scoop of ice cream slipping off a cone. It's a surgical emergency, typically presenting with hip or knee pain and an altered gait.
Okay, let's delve into bone metabolic diseases, where the disruption of that osteoblast-osteoclast balance leads to massive structural problems.
Starting with achondroplasia. This is the most common cause of short-limb dwarfism. It's a fundamental defect in endochondral ossification, the process of replacing cartilage with bone, which limits longitudinal growth.
And what's the molecular mechanism?
It's an activating mutation of the FGFR3 gene, the fibroblast growth factor receptor 3. This receptor normally acts as a negative regulator of chondrocyte proliferation, but when it's overactive, it prematurely shuts down the growth plate.
Leading to short, thick bones.
Right, but typically a normal-sized trunk and head.
Next, the ubiquitous problem of osteoporosis.
Osteoporosis is a disease of quantity. It's characterized by decreased bone mass and mineralization, affecting both cortical and trabecular bone. We diagnose it based on a DEXA scan, specifically a T-score of negative 2.5 or lower.
We've established that estrogen loss and age are key factors, but glucocorticoid use is probably the single most common iatrogenic cause.
It is. Glucocorticoids directly inhibit osteoblast function and increase osteoclast activity. Other risks include smoking, low BMI, lack of exercise, and secondary causes like hyperparathyroidism. The classic fractures are vertebral wedge fractures, hip fractures, and collis fractures, which is a discal radius fracture with dorsal displacement.
Okay, now the opposite extreme, osteopetrosis or stone bone.
This is a failure of normal bone resorption due to defective osteoclasts. The result is abnormally dense, thick bones that, paradoxically, are brittle and fracture easily because they lack proper remodeling.
So they're thick but weak.
Exactly. The defective osteoclasts fail to create the necessary acidic environment to dissolve the mineral.
And the clinical consequences are severe because of the dense bone encroaching on vital space.
The symptoms reflect the obliteration of the marrow space, which causes pancytopenia, a lack of all blood cells, and the narrowing of bone foramina, leading to cranial nerve impingement, such as hearing loss or visual disturbances.
Now we move to the defective mineralization of osteoid osteomalacia in adults, or rickets in children.
This is a qualitative defect, almost always caused by vitamin D deficiency. Vitamin D is essential for absorbing calcium and phosphate from the gut. Without it, the osteoid is laid down correctly, but it cannot be properly mineralized. In children, the lack of mineralization results in bowing of the legs and widening of the epiphyses.
And the lab findings here are a classic pattern we absolutely have to know.
You'll see low serum calcium and low phosphate. Because the body senses low calcium, it triggers an increase in PTH to try and pull calcium from the bone. And the increased osteoblast activity, which is trying to mineralize, results in an elevated alkaline phosphatase.
Finally, the highly localized chaotic remodeling known as Paget disease of bone.
Paget disease is a localized, disorganized process involving 3 stages: a destructive phase where osteoclasts dominate, a mixed phase, and finally a sclerotic phase where osteoblasts dominate. The result is a chaotic, non-functional mosaic pattern of woven and lamellar bone. The bone is enlarged but very weak.
And the complications are critical, especially given the increased vascularity of this abnormal bone.
They include hearing loss due to skull thickening, high-output heart failure due to the body shunting so much blood through the highly vascularized bone, and the risk of malignant transformation into osteosarcoma.
And the lab finding.
The only consistent lab abnormality in Paget disease is a massive unexplained elevation of ALP.
Another painful condition related to compromised circulation is a vascular necrosis, AVN.
AVN is the death of bone and marrow due to infarction, and it's usually very painful. The most common site is the femoral head because the medial circumflex artery is highly susceptible to injury. We remember the causes with many mnemonics, but the big ones are corticosteroids, alcoholism, sickle cell disease, and trauma.
This is a perfect point for a synthesis exercise. Let's use the source table to quickly review the lab values in bone disorders and highlight the crucial patterns you must recognize instantly.
The relationship between calcium phosphate and PTH is the diagnostic key. For osteoporosis and most bone tumors, the labs are normal, except for Paget's ALP. The disease is quantitative, a loss of mass, not qualitative, a lack of mineralization.
Contrast that with the vitamin D deficiency state, osteomalacia rickets, which we just noted. Low calcium, low phosphate, high PTH, and high ALP.
Now compare that exact pattern to its opposite, hypervitaminosis D. This occurs with oversupplementation. Vitamin D increases the absorption of both calcium and phosphate from the gut.
So everything goes up.
The result is high calcium, high phosphate. And because the high calcium suppresses PTH release, you get low PTH. That pattern is the core distinction from rickets.
And the high PTH, high calcium pattern of chronic hyperparathyroidism.
That's the pattern that leads to osteitis fibrosis cystica. High PTH causes constant, aggressive bone resorption, which drives high serum calcium. So you see high calcium, often low or normal phosphate, high PTH, and high ALP.
Okay, let's look at the frightening category of primary bone tumors. We categorize these strictly by age and their location within the long bone.
Starting with the benign tumors. The most common is the osteochondroma or exostosis, seen in people under 25. It presents as a projection of bone capped with cartilage from the metaphysis, the growth plate area, and it extends away from the joint. It has a small risk of malignant change.
Then you have the pain relieved by NSAIDs tumor, the osteoid osteoma.
Also typically seen in people under 25, usually in the cortex of long bones. The unique feature is the pain, which is often severe at night, but is dramatically and completely relieved by NSAIDs. This is because the tumor produces excessive prostaglandins, which NSAIDs inhibit.
And the locally aggressive tumor of the epiphysis.
The giant cell tumor, seen in the 20 to 40 age range, classically located at the epiphyseal end of long bones, often around the knee. On X-ray, it has distinct soap bubble appearance.
Moving into the malignant tumors, the first is osteosarcoma.
This is the most common primary bone cancer. It peaks in adolescence, between 10 and 20 years old, and commonly occurs in the metaphysis of long bones, especially the distal femur or proximal tibia. Risk factors include previous radiation and Paget disease.
And the radiological signs are critical for diagnosis.
You look for the classic aggressive features, the Codman triangle, which is an elevation of the periosteum creating a triangular shadow, and the aggressive sunburst pattern of new bone formation perpendicular to the cortex.
Finally, the highly aggressive small blue cell malignancy, Ewing sarcoma.
Ewing sarcoma is most common in white males under 15 years old. Unlike osteosarcoma, it affects the diaphysis or the shaft of long bones or pelvic flat bones. Histologically, it's a small blue cell malignancy.
And the genetic signature that defines it.
It is strongly associated with the T1122 translocation, which creates the EWS-FLI1 fusion protein. Radiographically, it exhibits the characteristic onion skin appearance due to layers of reactive periosteal bone formation. It is highly aggressive but often responsive to multimodal chemotherapy.
Shifting gears again, let's turn our attention to arthritis, the systemic inflammatory and mechanical diseases of the joints. We absolutely must start by deeply contrasting the two biggest hitters, osteoarthritis versus rheumatoid arthritis.
This contrast is foundational. Osteoarthritis is a mechanical, non-inflammatory process. The pathogenesis is the slow, relentless destruction of articular cartilage due to wear and tear, and the inadequate repair response by local chondrocytes. The damage is a consequence of years of use.
So mechanically driven and often asymmetric, how does the pain presentation differ?
The pain occurs in weight-bearing joints, hips, knees, lumbar spine. The key differentiator is that the pain improves with rest and worsens throughout the day, often associated with short periods of stiffness after inactivity. And the joint involvement is asymmetric and localized.
What are the pathological findings?
You see osteophytes, or bone spurs, subchondral cysts, and asymmetric joint space narrowing. The classic nodes are bony enlargements, Heberden nodes at the DIP joints and Bouchard nodes at the PIP joints.
Okay, now, rheumatoid arthritis, the systemic inflammatory opposite.
RA is an aggressive, chronic autoimmune disorder, strongly associated with HLA-DR4 and environmental triggers like smoking. The immune system generates a destructive, invasive granulation tissue called the pannus, which invades and destroys the cartilage and adjacent bone.
And the presentation here is distinct. It screams inflammation.
Patients present with severe pain and swelling, and the hallmark is prolonged, debilitating morning stiffness lasting more than 1 hour, which then improves with use and activity. The involvement is classically symmetric, affecting the small joints like the MCPs, PIPs, and wrists.
That sounds horrific. If the patient is struggling that much, what is the single most critical intervention needed medically before the joint architecture is irrevocably destroyed by the pannus?
Immediate and aggressive intervention with disease-modifying antihemolytic drugs, or DMARDs, like methotrexate or TNF-alpha inhibitors, is critical. Waiting means allowing that pannus to erode the bone, leading to permanent deformities like ulnar finger deviation and swan neck deformities. Early, aggressive treatment is the only way to preserve function.
Next up, the crystal arthropathies gout and pseudogout. The name comes from what's literally found in the joint fluid.
Gout is caused by acute inflammatory attacks triggered by the deposition of monosodium urate crystals. The strong risk factor is hyperuricemia, which can be due to overproduction, like in tumor lysis syndrome, or more commonly, underexcretion by the kidneys.
And the classic presentation is agonizing.
The acute attack is intense. A painful, red, swollen, asymmetric joint, most common in the first MTP joint of the big toe, which is known as podagra. Chronic untreated gout leads to white, chalky deposits called tophi.
And the key to definitive diagnosis lies in the crystal analysis under polarized light.
Gout crystals are needle-shaped and exhibit negative birefringence, meaning they appear yellow when aligned parallel to the polarizing light. We treat the acute flare with NSAIDs, colchicine, or glucocorticoids. Chronic prevention involves lowering uric acid production with allopurinol or febuxostat, or increasing excretion with probenecid.
Contrasting that is calcium pyrophosphate deposition, CPCD, or pseudogout.
This is the deposition of calcium pyrophosphate crystals. It tends to affect older patients, is often associated with metabolic conditions like hemochromatosis or hyperparathyroidism, and typically involves larger joints like the knee or wrist.
And the crystal analysis provides the definitive opposing contrast.
CPPD crystals are rhomboid-shaped and exhibit positive birefringence, meaning they appear blue when aligned parallel to the light. We remember that the blue of CPPD is the positive opposite of the yellow of gout. Acute flares are treated similarly with NSAIDs or colchicine.
Okay, let's cover a few other inflammatory and infectious conditions, starting with the autoimmune destruction of exocrine glands. Sjogren's syndrome.
Sjogren's syndrome is characterized by the autoimmune destruction of exocrine glands. The two hallmark clinical findings are debilitating xerostomia, or dry mouth, and xerothalmia, or dry eyes, which is often described as a gritty, sandy sensation.
And the antibodies are key here.
Patients are typically positive for rheumatoid factor, and specifically for anti-SSA, or Rho, and anti-SSB, or LA, antibodies. The most serious long-term complication is the significantly increased risk of developing B-cell non-Hodgkin lymphoma, often MALT lymphoma.
The next major category is septic arthritis. A single red-hot swollen joint is an orthopedic emergency.
It demands immediate attention. Septic arthritis is usually bacterial, most commonly S. aureus, streptococci, or N. gonorrhea in sexually active young adults. The diagnosis is made by aspirating the joint fluid, which typically shows a PMN count greater than 50,000. Prompt antibiotics and joint drainage are required to prevent permanent joint destruction within days.
Lastly in this section, let's define the seronegative spondyloarthropathies.
These disorders share key features summarized by the PR mnemonic: psoriatic, ankylosing spondylitis, arthritis associated with IBD, and reactive arthritis. They're all associated with the HLA-B27 allele, and they frequently involve inflammation where tendons insert into bone enthesitis and swelling of entire digits, or dactylitis, the sausage fingers.
And ankylosing spondylitis is the most dramatic in terms of structural change.
It causes symmetric inflammation and fusion of the spine and sacroiliac joints, leading to the characteristic bamboo spine on X-ray. The fusion of costovertebral joints can severely restrict chest wall movement, leading to restrictive lung disease.
And reactive arthritis is known for its classic triad.
The triad is conjunctivitis, urethritis, and arthritis, the famous rhyme. Can't see, can't pee, can't bend my knee. It's an autoimmune response that follows a recent infection, often gastrointestinal, like Shigella or Salmonella, or genitourinary, like chlamydia.
We transition to systemic vasculitis. These are inflammatory disorders of the blood vessel walls, and the diagnostic key is strictly categorizing them by the size of the affected vessel.
We begin with large vessel vasculitis.
Giant cell arteritis, or temporal arteritis, is a condition of older women, typically over 50.
It causes granulomatous inflammation of arteries branching off the carotid. The presentation includes a severe unilateral headache, tenderness over the temporal artery, jaw claudication, and the terrifying risk of rapid, irreversible vision loss due to ophthalmic artery occlusion. It is strongly associated with polymyalgia rheumatica.
That is terrifyingly fast. Does that mean treatment needs to be initiated based on suspicion alone, often before a biopsy is even performed?
Absolutely. Because vision loss is often permanent, you must start high-dose glucocorticoids immediately upon clinical suspicion, even while waiting for the temporal artery biopsy to confirm the diagnosis. You cannot wait.
The other large vessel disease is Takayasu arteritis.
This affects younger Asian females, typically under 40. It causes granulomatous inflammation of the aorta and its major branches, leading to stenosis. It's famously known as the pulseless disease because of weak or absent upper extremity pulses due to obstruction.
Okay, now medium vessel vasculitis. First, Berger disease.
This is almost exclusively seen in heavy tobacco smokers under age 45. It involves segmental thrombosing vasculitis of medium vessels, leading to intermittent claudication, gangrene, and superficial vein thrombosis in the extremities. The treatment. Cessation of smoking is the only effective therapy.
Kawasaki disease is the critical pediatric vasculitis.
Affecting Asian children under 4. It presents with a prolonged fever, a non-polymorphous rash, bilateral conjunctivitis, strawberry tongue, and cervical lymphadenopathy. The critical complication we treat aggressively for is the risk of coronary artery aneurysms and thrombosis, which can be fatal. It's treated with IVI and aspirin.
The third medium vessel vasculitis is polyarteritis nodosa.
PAN is a necrotizing vasculitis that classically involves renal, GI, skin, and nervous systems, but notably spares the lung. It is often associated with hepatitis B seropositivity. On angiography, the aneurysms and constrictions give it a characteristic string of pearls appearance.
Finally, the small vessel vasculitis. We divide these by their association with ANCA.
The PANCA diseases, like microscopic polyangiitis, cause necrotizing vasculitis involving the lungs and kidneys, but without granulomas.
And the CANCA disease is granulomatosis with polyangiitis, or Wegener's.
This is defined by the triad. Involvement of the upper respiratory tract, causing inflammation and saddle nose deformity, lungs, vessels, and kidneys, which is a rapidly progressive glomerulonephritis. The presence of CANCA antibodies targeting proteinase 3 is highly specific.
And quickly mentioning the immune complex small vessel forms like EGA vasculitis, Hanoch-Schönlein purpura.
This follows an upper respiratory infection and is characterized by the triad of palpable purpura, a non-blanching raised rash arthralgias, and abdominal pain.
We transition to neuromuscular junction diseases, where the communication between nerve and muscle breaks down. The classic pair here is myasthenia gravis and Lambert-Eaton myasthenic syndrome. The distinction is purely structural.
Myasthenia gravis is the common one. The pathology involves autoantibodies targeting the postsynaptic acetylcholine receptors. This destroys the receptors, leading to less efficient signal transmission.
Clinically, it presents with fatiguing muscle weakness, ptosis, or droopy eyelids, diplopia or double vision, and proximal weakness that worsens with continued use because the remaining receptors quickly tire out.
It is strongly associated with thymoma or thymic hyperplasia. The diagnosis is confirmed by the fact that symptoms dramatically reverse when you administer AKE inhibitors like pyridostigmine, which lets the small amount of remaining HE linger longer in the synapse.
Now the opposite story, Lambert-Eaton myasthenic syndrome, LEMS.
LEMS is less common, involving autoantibodies targeting the presynaptic voltage-gated calcium channels. This impairment means the nerve cannot release enough HE into the synaptic cleft.
But the clinical course is different. Proximal muscle weakness, but it improves with repeated use. Why?
Because repeated nerve firing helps to gradually mobilize and release the limited HE supply. Critically, LEMS is a classic paraneoplastic syndrome, associated in most cases with small cell lung cancer. The L in LEMS comes before the M in MG, just as you often diagnose the lung cancer before the myasthenia-like symptoms.
Finally, quick mention of Raynaud phenomenon.
This is vasospasm of small cutaneous vessels due to cold or stress. It leads to the classic triphasic color change. white for ischemia, then blue for hypoxia, and finally red for reperfusion. It can be primary or secondary to connective tissue diseases like CREST syndrome.
We have spent extensive time mapping the mechanics of the frame. Let's transition now to the largest organ in the body, the protective barrier. The skin, starting with the epithelial cell junctions, the structural glue.
Understanding the specific glue is vital because this is where autoimmune blistering diseases launch their attacks. We have tight junctions using occludin and claudin, which are the seal, preventing pericellular solute movement.
Then the adherens junctions with cadherins, which form a belt connecting the actin cytoskeletons. We noted that losing ecadherin is a key step in cancer metastasis.
And the desmosomes, with desmoglein and desmoplakin, which are the spot welds, anchoring intermediate filaments. This is the crucial target of autoantibodies in pemphigus vulgaris.
And the connection to the underlying dermis? Hemiadesmosomes.
Hemiadesmosomes, using endocrines, anchor the basal layer cells to the basement membrane. This is the target of autoantibodies in bullous pemphigoid.
Okay, we can differentiate the various skin infections based on depth, starting superficial, impetigo.
Impetigo is superficial, highly contagious, caused by S. aureus or S. pyogenes, and it's characterized by thick, honey-crusted lesions.
Going deeper, we hit erysipelas and cellulitis.
Erysipelas is an infection of the upper dermis, typically S. pyogenes. The defining feature is a sharply raised, well-defined line of demarcation separating the infected and healthy skin. Cellulitis is a deeper, spreading infection of the dermis and subcutaneous tissues, also from S. pyogenes or S. aureus, and it presents with poorly defined borders.
The ultimate emergency is necrotizing fasciitis.
This deep infection attacks the fascia and muscle layers. The key is pain out of proportion to the exam findings, sometimes with crepitus or gas production. It requires immediate surgical debridement to save the limb and the patient's life.
And don't forget the toxin-mediated diseases like staphylococcal scalded skin syndrome.
SSS is caused by an exfoliative toxin that destroys the epidermal-dermal junction. It's common in newborns and is positive for the Nikolsky sign. The top layer of skin separates upon light pressure.
Okay, now back to those critical autoimmune blistering disorders. Let's use the epithelial junctions to differentiate pemphigus vulgaris and bullous pemphigoid.
Pemphigus vulgaris attacks the desmosomes, which is desmoglein 3 and 1, causing an intraepidermal split. The resulting blisters are flaccid, mucosal involvement is common, the Nikolsky sign is positive, and immunofluorescence shows a reticular pattern around individual cells.
And bullous pemphigoid is the exact structural opposite.
It attacks the hemiosmosomes on the basement membrane, causing a subepidermal split. The blisters are tense and strong, the oral mucosa is typically spared, the Nikolsky sign is negative, and immunofluorescence shows a linear pattern at the junction.
That structural distinction is the high-yield nugget. Let's quickly touch on dermatitis herpetiformis.
This involves intensely itchy papules and vesicles, and it's highly associated with celiac disease. We see IgA deposits at the dermal papillae tips.
And the severe mucocutaneous reactions, Stevens-Johnson syndrome, and toxic epidermal necrolysis.
These are life-threatening drug hypersensitivity reactions involving extensive mucosal damage. SJS involves less than 10% of the body surface area. 10 involves more than 30%. They carry very high mortality rates and require intensive care.
Okay, now we examine cutaneous ulcers. You need to look at location, appearance, and pain level to determine the etiology.
Venous ulcers are the most common. Location, the gaiter area, from ankle to midcalf. Appearance, irregular border, shallow and exudative. Pain, mild to moderate. They're caused by chronic venous insufficiency and stasis dermatitis.
And arterial ulcers are caused by a severe lack of blood supply.
Location, distal toes, anterior shin. Appearance, symmetric, sharply defined and punched out. Pain, severe, excruciating pain. The limb is cold, pale, and pulses are often absent or severely diminished.
Neuropathic ulcers are a complication of diabetes.
Location, bony prominences or pressure points like the soles of the feet. Pain, absent due to peripheral neuropathy. They are associated with Charcot joint and hyperkeratotic edges, often caused by unrecognized repetitive trauma.
Let's wrap up the skin's defenses with a look at burn classification.
The key is linking depth to pain and appearance. Superficial burns, first degree, are epidermis only. They're painful, red, and they blanch. Superficial partial thickness burns, second degree, involve the papillary dermis. They're painful, blistered, and they also blanch. Deep partial thickness burns involve the reticular dermis. They are white or waxy, dry, inelastic, less painful, and do not blanch.
And the most severe burn?
Full thickness burns, or third degree, involve the entire dermis and are typically white, waxy, and completely painless because the nerve endings have been destroyed. We use the rule of nines for a rapid estimation of surface area for fluid resuscitation.
Moving to the malignant threats to the skin. Skin cancer.
Basal cell carcinoma, or BCC, is the most common. It classically affects the upper lip. It presents as a pearly nodule with rolled borders and telangiectasias. It's locally invasive but almost never metastasizes.
And squamous cell carcinoma, SCC.
SCC often affects the lower lip. Its precursor is the actinic keratosis. It presents as a scaling plaque with crusting. Risk factors include chronic wounds and immunosuppression.
And melanoma, the most dangerous.
Melanoma has the highest risk of metastasis. We rely on the ABCDEs for diagnosis. Asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, and evolution. The critical prognostic indicator is the Breslow thickness. The depth of invasion correlates directly with metastatic risk.
So what does this all mean? We've seen inflammation driving massive pathology, from the pannus and RA to the pain of gout. Let's trace the chemical cascade that drives this inflammation, the arachidonic acid pathway, and see exactly where our pharmacological tools intervene.
This pathway is the central hub of inflammation. It starts with membrane phospholipids being converted into arachidonic acid by the enzyme phospholipase A2. This is the first intervention point. Glucocorticoids inhibit PLA2, effectively shutting down the entire cascade right at the source.
Okay, and once we have arachidonic acid, it branches. First, the COX pathway.
The COX1 and COX2 produce prostaglandins, which are mediators of pain, fever, and inflammation, and thromboxane, which causes platelet aggregation. This is where NSAIDs target.
And the second branch is the 5-lipoxygenase pathway.
This converts arachidonic acid into leukotrienes. LTB4 is a potent neutrophil chemoattractant drawing immune cells in. LTC4, D4, and E4 are the severe bronchoconstrictors and vascular permeability agents.
And this gives us our asthma drug targets.
Exactly. Xeloton inhibits the 5-lipoxygenase enzyme itself, blocking production. Montelukast and zafralukast are leukotriene receptor antagonists, blocking the action of those bronchoconstrictors.
Okay, let's focus on the nonsteroidal anti-inflammatory agents. We must isolate acetaminophen first.
Acetaminophen reversibly inhibits COX, but primarily in the CNS. It is an analgesic and antipyretic, but it is not anti-inflammatory because it's inactivated peripherally. The risk is hepatotoxicity in overdose due to the NAPQI metabolite, which is treated with N-acetylcysteine.
Then you have aspirin.
Aspirin is unique because it is an irreversible COX1 and 2 inhibitor. Its antiplatelet effect is permanent, lasting the entire 7-day lifespan of the platelet due to irreversible thromboxane reduction.
And standard NSAIDs like ibuprofen and indomethacin are reversible COX1 and 2 inhibitors. What are their critical risks?
Their main risks are GI ulceration and kidney damage. They cause renal ischemia because, by inhibiting prostaglandins, they prevent the necessary vasodilation of the afferent arteriole. Indomethacin also has a specialized use, closing a PDA, or patent ductus arteriosus.
And the selective inhibitor, celecoxib.
Celecoxib selectively inhibits COX2, which reduces the GI side effects because it spares COX1, which maintains the gastric mucosa. However, it carries an increased risk of thrombosis.
Okay, let's detail the targeted treatments for autoimmune and bone disease. Starting with bone loss, the first line is usually bisphosphonates.
Alendronate and risdronate are pyrophosphate analogs. They bind to bone mineral and promote osteoclast apoptosis. They stabilize the bone structure, used for osteoporosis and Paget disease. Key adverse effects include osteonecrosis of the jaw and atypical femoral fractures.
For severe osteoporosis, we turn to the rebuilding agents, recombinant PTH analogs.
Teriparatide or abaloparatide. This is PTH given in a pulsatile fashion, an intermittent low dose, which shifts the balance entirely toward anabolic activity, stimulating osteoblasts to build new bone.
Now, the definitive drugs for gout. We need to know the production reducers versus the excretion enhancers.
Chronic prevention involves reducing uric acid. Allopurinol and febuxostat are xanthine oxidase inhibitors that decrease uric acid formation. Probenecid is a uricosuric agent. It inhibits uric acid reabsorption, increasing its excretion.
And for an acute flare, the treatment is purely anti-inflammatory.
Acute flares use NSAIDs, glucocorticoids, or colchicine. Colchicine works by binding and stabilizing tubulin, which halts the migration and phagocytosis of leukocytes, effectively stopping the inflammatory attack launched by the crystals.
Finally, the revolutionary class of biologics, especially the TNF-alpha inhibitors.
TNF-alpha is a master cytokine in systemic inflammation. Etanercept, adalimumab, and infliximab block its activity, used extensively for RA, psoriasis, and ankylosing spondylitis.
And the major life-threatening adverse effect must be highlighted.
Blocking TNF-alpha dramatically impairs the immune system's ability to wall off latent infections. This predisposes the patient to serious infection, critically including the reactivation of latent tuberculosis, because TNF-alpha is essential for maintaining the granulomas that contain Mycobacterium tuberculosis.
We have covered a colossal amount of material today, moving from the precision of nerve mapping through the pathology of bone down to the molecular pharmacology of inflammation and the defense systems of the skin.
The key takeaway, really, is recognizing patterns and exploiting contrast. We mastered the differentiation between all the claws and drops based on the precise level of the nerve lesion. We contrasted the mechanical OA from the inflammatory RA and the negatively birefringent needles of gout from the positively birefringent rhomboids of pseudogout.
And we connected the dots structurally, how small changes, like a single overactive gene in achondroplasia, or the structural collapse caused by the pannus in RA, cascade into systemic failure. We now know exactly where targeted therapies intercept complex molecular pathways like TNF-alpha or the DHPR-RYR coupling.
Understanding these interconnected systems means understanding the precarious balance that maintains stability, movement, and defense.
Here's a final provocative thought for you to mull over. The human frame is fundamentally upheld by two competing, opposite, yet vital processes. Destruction, the osteoclast, the immune cell, the catabolic enzyme, and reconstruction, the osteoblast, the repair cell, the anabolic hormone. Consider how many of the pathologies we covered, from osteoporosis, where destruction wins, to Paget disease, where the balance is chaotic, and even autoimmune diseases, where immune destruction attacks the junctions of the skin or the cartilage of the joints, are simply a result of this fundamental, necessary opposition going horribly awry. What else in the body operates on such a precarious, necessary opposition? And what happens when the tension between those two opposing forces finally snaps?
Until next time, keep that curiosity firing.